Well, welcome to Optometry Education Consultants National Webinar Series. Our title tonight is the Oculoplastic O.D. with Dr. Selina Mcgee. She's a founder and owner of Bespoke Vision, a boutique private practice that offers patients a wide range of optometric care by its Dry Eye Center of Excellence, specialty contact lens clinic, and its aesthetic suite. The practice also performs extensive pathology management and laser and minor surgical procedures. In addition to her private practice, Dr. Mcgee is an adjunct assistant professor at Northeastern State University's College of Optometry in Tulsa, Oklahoma. She also sees Sjogren's patients with the Oklahoma Medical Research Foundation. She has many relationships with industry. She has numerous publications to her credit. She has lectured nationally and internationally at all of our large meetings, as well as in Canada. And she is a graduate of the Northeastern State College, University's College of Optometry. So with that, I'd like to have a nice virtual warm welcome for Dr. Selina Mcgee, and she talks about the Oculoplastic O.D. So with that, Dr. Mcgee, please take it away.
Perfect. Thanks, Joe. Thanks, Greg. Thanks, Vanessa. And welcome, everybody. This is going to be a fun evening, and there's a lot of slides in this deck, which is why Greg has to compress it. So I'm going to jump in. And as Joe said, I'm in Oklahoma. I've been in private practice for a long time, but we've added some really cool things to our repertoire of what we're doing with our patients. So there's disclosures. So let's start with, how we see ourselves and what sometimes is happening in real life when we look in a mirror, right? And our patients are like this too. So with that, I'm going to open up, I'm going to do our first poll like right off the bat. So if you'll kick that first one off. So what's your practice differentiator? And I know there's lots more than this, but, I want you to think about that. What's different between you and another doctor down the street? Specialty contact lenses, traumatic brain injury, ocular disease, dry eye disease. What does that look like for you? And we're going to talk about tonight maybe something different that you might not have thought about, or maybe you have. And we'll just give you some more pearls on how to expand it. Okay.
All right, there you go.
Ocular disease wins 52%, and then 18% specialty contact lenses, dry eye coming in at 25%, TBI smaller percentage, 5%. What I love about optometry is there's so many, we could list probably, 10 or 15 more there. And so this is what we're gonna, walk through tonight is how do you differentiate yourself? And this is different than what we've typically thought of as what optometry really is. But I want us to start thinking about what comprehensive eye care really means, because there's a whole person behind that set of eyeballs. And guess what? There's a whole lot of skin and there's a whole lot of things happening around those eyeballs that we're looking at, and we're helping people see better. And so I want us to start to think about how do we also help patients not only see better, but feel better about themselves. What is it that you and I can do that's a specialty niche that only you and I have the knowledge for? And there's tons, as it turns out. So I'm curious, and here's our second poll. What percent of your patients talk to you about the cosmetics that they use? 1%, 11%, 21%, 41%. What does that look like for you in your clinic? How many of your patients are saying, hey, which mascara should I use? Or, how do I put my makeup on this way? Or how do I take my eyeliner off? Or is waterproof mascara good? What do you guys think?
And Selena, when you get to the point of your eyelashes, as looking at your handout, I have a pretty cool story to tell you.
Okay.
So, but I'll wait to that point. So.
Okay. And if you were like me, whenever I used to get asked those questions, it was kind of like deer in the headlights. 1%, 64%, 11%, 28%, 21%, 9%, and then 41%, no one said. So what it really is across the country is actually 11%. And this is why we're having this conversation tonight, because patients are asking these questions. They're doing things that are sabotaging the front surface. They're doing things that are sabotaging what you and I are doing for their dry eye disease. And we are the only profession that has a microscope to look at the surface of the eye and look at the skin around the eyelids. So this was an Academy poster that my good friend Leslie Odell put together and presented at AAOpt in 2016. And so what we're going to talk about tonight is thinking differently about what is comprehensive eye care. So we're going to talk about cosmetic offenders. We'll talk about habits that are harmful, you know, for all my people out there that are like, I don't know where eyeliner goes. I've never touched that. I don't even know what it's supposed to do. We're going to talk about that and easier ways to have conversations. And then we'll talk about injections. I've been doing neurotoxin in my clinic for the last 4 years, non-invasive procedures that you all can do, minimally invasive procedures that we can do, and then invasive surgical procedures that we co-manage with. And so not only do we have this particular skill set to be part of these conversations, but in my opinion, we should be leading this because we know a whole lot more than we think we do. So this is my website, just a little snippet of what this looks like in my clinic. We've got eye care, we've got specialty contacts, eye health, and then you see on the top of there, eye rejuvenation. There's a whole section there. Before I get to that slide, okay, here's our other poll. What do you think the average amount of money that the average female in the US spends on cosmetics? $800 a year, $1,800 a year, $2,800 a year, or $3,800 a year? Hopefully that slide didn't flash fast enough for anybody to get a sneak peek.
I didn't see it.
Okay, good.
Good poll results tonight. They're quick on this. They're liking
Love
this,
it.
Selina. That's
Love
good. Usually it takes a little bit longer, but we've gotten some good percentages here. Share those results.
Okay. 800, 1,800, 2,800, and 7% said 3,800. So the 7%ers were correct. The average female spends $3,800 a year on cosmetics, and $15 billion will be spent on the global influencer marketing in 2022. The whole entire industry is $440 billion. But what I'm getting at here is social media is who's driving these trends. And it's your influencers who are getting paid by these companies to be the influencer, right? So this is why we want to have this conversation, because when women are spending that amount of money on cosmetics, and you'll see some interesting things that as it turns out, they're spending money on nothing. You and I can be the ones that are driving trends safely and effectively so people aren't doing things harmful to the front surface of their eye. So I always like to ask everybody, like in the audience, when I'm doing this question and this slide deck, how many people, and I obviously can't see everyone, but how many people on here are selling frames in their optical? How many people are writing prescriptions for contact lenses? How many people own a slit lamp, right? Pretty much usually every hand in the audience goes up. So we're already halfway there. We're already doing aesthetics. People buy frames because they want to look different. People put on a contact lens because they don't like the way they look in glasses. And again, we have a microscope that we're looking at all of this. So eyelash enhancement is a huge craze right now. We're going to talk about, and then all of the things. And so my point to that is you already are halfway there. You know a lot more than you think you do. And the last year has really elevated this conversation, because not only are we talking about blue light off of screens and thinking about what that does to the inside of our eye, we know it messes with circadian rhythms, but it also messes with our skin. And so that's a big piece of this conversation too. And then when you look at actual sales, because everybody was wearing a mask, eye makeup sales went up 204% over the pandemic. Lipstick sales, shockingly, or not shockingly, dropped by 28%. And so now is the time to be having these conversations because more people are doing these things. So when you look at the top 5 cosmetic surgical procedures, over the last 20 years, this really hasn't changed percentage-wise. The numbers have gone up, but blepharoplasty continues to be number 4. And the top 5 minimally invasive continues to be neurotoxin number 1 and dermal fillers number 2. And then IPL falls into at number 5. And so those are all things that we're either co-managing, our patients are having done that we need to know about, we could be doing, and we are doing in our clinics. So again, this is just headlines that are coming through, you know, taking care of your eyes. And one of the biggest pearls of tonight is don't forget about sunglasses. So we always talk about sunglasses and the progression of cataracts and helping prevent macular degeneration. But the other piece to that is skin cancer, because nobody puts sunscreen on their eyelids. And that's a great question to ask your patients. Are you putting sunscreen on your eyelids? Because the resounding answer is going to be no, because they don't want to put it in their eyes because it's going to sting and burn. So if they don't have sunglasses on or good sunglasses on, they're just getting blasted and that whole part of their skin is exposed. And that's why you'll see some stats later on in the talk about skin cancer on our eyelids.
Excuse me, Selina?
Yeah.
I got a quick question.
Yeah.
Is there any sunscreen that is approved to be on the eyelids? Because most sunscreens say do not use on the eyelid. And I know somebody who didn't follow that and led to a huge toxic reaction because it's so easily diffused through the thin skin of the lid. Is there anything that is safe to use?
So there is, and there's a couple of things to avoid. So we will, and there's a whole like 4 or 5 slides just on sunscreen alone. So that's a great question, and we will get to that. Because the other part too is if you're using, you know, the chemical sunscreen, that absorbs in your bloodstream within 15 minutes, which we don't want. So we'll talk about ingredients. So what is a cosmetic? Anything that's rubbed, poured, sprinkled on, or sprayed on the body. We use them to cleanse. We use them for anti-aging. We use them for beauty. But there's a whole lot of risks with these. Some of these are carcinogenic, endocrine disruptors. Neurotoxin can cause problems if we're too aggressive with it. You know, and when we get these on the ocular surface, we get, you know, contamination of the tear film. And we've all had those patients where they blink and you just see like makeup like swim through, right? And you're like, what do I do about this? And it can irritate the cornea conj, stress the surface. It can cause meibomian gland dysfunction. You're going to see ingredients that actually clog up the meibomian glands. It can contribute to loss. And when I, you know, put that up on my screen in my exam room and patients are like, why do I not have any like glands right there? And so we have a conversation around this. Create tear film instability, and it can cause or exacerbate dry eye. So the average female exposes herself to 167 chemicals a day. And guess what? Okay, time for another poll while I keep everybody engaged. So our next question is, what year did the FDA update the Cosmetic Act in the US? 1938, 1978, 1998, 2008. What do you guys think? When was the last time the FDA updated that Cosmetic Act? Considering that we're using lots of chemicals these days. See what you guys think.
We're rolling in nicely here.
Okay.
I don't think you can see that on your end, so I'll give you the update.
So I love it. Thank you.
In order to make these live and interactive and meet the COPE compliance, that's why we do the polling questions. They like to see a certain percentage of people reply. So
I like the polls. It just keeps everybody on our toes. And I always remember things more when I physically either type it in or think about it. So.
All right, I'm going to end the poll.
Okay, let's see what you guys think. 1938, 10%, 1978, 59%, 1998, 24%, 2008. So the answer is 1938. Can you believe that? The FDA has not touched this since 1938. And that's everything. Lipstick, blush, foundation. What we're most focused on is eyeliner, eyeshadow, and mascara. So when I roll out with this statistic to patients, they're shocked, and then they're typically really angry when I tell them that what they're paying for is an haute couture label that means absolutely nothing. Hypoallergenic means nothing. Fragrance-free means nothing. All of those things, nobody regulates. Nobody manages that in the US. So when you look at the regulations of what's banned in the US, we have 11 chemicals versus over 1,300 chemicals in Europe. So that just gives you a little snippet of anything that can be in a product. And also, if it doesn't meet a certain percentage, but could still be causing a problem, they don't even have to put it on the label. So this all impacts ocular surface, because when you've got makeup, just like this picture, you know, clogging meibomian glands, and patients aren't taking their makeup off. I mean, that looks like that's been there a long time, right? Those are all conversations that we have to have, because here's what happens, right? I mean, when you look at TFOS Deuce 2 and you look at all of this piece, it affects every single circle of dry eye disease. So let's talk about, eye makeup in general. Do patients ask you those questions? What kind of eye makeup should I use? What brand is best? Do they talk about how to take it off? What kind of mascara should I use? The extensions we're going to talk about, and Greg's got a good story, it sounds like. And then where to apply and what to avoid. And I have a really good friend who is an amazing optometrist. He actually was the first OD in the country to do PRK. He's brilliant. And his conversation around this was, I just tell my patients not to wear makeup, Selina. He's like, and I was like, really? How's that working out for you, man? Right? And he's like, is that bad? And I was like, yes, because they're not going to do that. That's not the answer. People are going to wear makeup and they're going to do things unless we have a conversation around, okay, let's talk about best practices, and we have to be able to help them through that. So we can't just say, stop wearing makeup, because that is unrealistic. So let's start at the top and work our way down, because brows and lashes too are having a serious moment. And when I got heavy into this about 5 years ago now, I really wanted to understand and study faces and what people are striving for and why we make the decisions that we do. Psychology has always fascinated me. And so there's a whole chapter that a plastic surgeon wrote on kind of the ideal. And he's like, the Disney princesses are actually a really good place to start, because Snow White was the first princess. And I think she came out in like the late 30s, 40s, 50s, somewhere in there. But as you notice, like all of these princesses look exactly the same. High cheekbones, narrow chin, full mouth, lashes on the ends. Brows are pretty much the same. The only thing that's different is hair color and eye color in their dress, right? These are all the same person. And so these are the measuring kind of faces that people look at, think about, and subliminally are getting exposed to. And so just an interesting thing. And brows are trendy, right? So I started with 1920 in that upper left-hand picture, totally flat and plucked, all the way down to the right picture where we are. And this is by decade, 20s, 30s, 40s, 50s, 60s, a Twiggy. And then Brooke Shields in the early 80s, Kate Moss again, it was like super thin, Tara Reid. And then now we've come full circle back to Brooke Shields again, and everybody wants these like really full brows. So brows are really trendy, and that's important because these are going to change. And you have to change with the times and look at what's happening that people are doing. So microblading is a huge thing right now, which is tattoo pigment into that hair follicle, which, by the way, that same little tattoo needle that's punching into that hair follicle is also the same one that punches through the meibomian glands when they do it on their lids. But you can have allergic reactions like this person had. It's going to destroy the hair follicle many times because of that needle. So, what we're doing today is probably going to be different than what it looks like tomorrow. This pigment tends to not, last forever either. They have to have that redone every like 3 to 5 years. And of course, the person doing that typically does not talk about the long-term effects. So let's talk about eyelashes and extensions, and now as far as extensions go, I mean, I used to have 1 or 2 people maybe a week. Now I have like 1 or 2 like an hour, and they are huge. And half the time the lashes like enter the room before the patient does, right? They're just crazy long. And our eyelashes are supposed to be an ideal length. They're supposed to be 1/3 of the eye width. And because our lashes are there to keep things off of the front surface, when we alter that, it actually creates a vacuum and pulls stuff onto the front surface. So it has the opposite effect of what it's meant to do. So false lashes, let's talk about, because people will glue these on, and they'll glue them on typically outside the waterline, but there's a new trend to glue them on inside the waterline, meaning they're putting glue right on top of the meibomian glands, which that glue is made up of formaldehyde and latex, which is a very common allergen and also very high offender for the ocular surface. There's magnetic liners that contain iron oxides, which is literally a magnetic that they paint on their eyelid, and then they use little magnets to put on either side of them. I had a patient that did this, luckily only on one eye, and when she went to take the little lash magnet off, all of her skin came with it. So we had a lovely lid abrasion from one side to the other, but thankfully one side. So people will do these, but look at the glue ingredients, have them do a patch test before they do this on their lids. Take breaks. The little individual lashes that go on the ends are better than like full strips. Keep it on the outside of the waterline and keep the lashes a third of the width of the eye. So I'll walk through this and then I'll let Greg share his story. So 1 to 3 hour process of gluing individual lashes to their anatomic lash. So when you're behind the slit lamp, you're going to see these lashes are glued to their anatomic lash, and there's a nice little gap in there for lovely critters and things to grow in. And they do filling and redoing their extensions typically every 2 to 4 weeks, because they're taking off the old and replacing with the new. And they've got glue solvents, fragrances, all kinds of stuff that winds up on the front surface of the eye. But this is one of those things that patients will do and will continue to do. We need to at least talk about how to clean these, because many times they don't clean them. And to look at the glue ingredients and take breaks from them, keep them at a certain length. I recommend that we clean them with hypochlorous acid because it won't mess with the glue. You can do a tea tree foam. Any kind of oil is off the table because it will dissolve the glue. If you have somebody that has this and they have contact dermatitis like this patient has, I mean, you can see them when you come into the room, it's all irritated. And if they want to take them off, send them back to the person that put them on, because they know what kind of glue they used, and the solvent needs to be what will dissolve that glue. If you try to do that in the office, it's going to wind up being a hot mess. So send them back and have them take them off from the person that actually put them on. Okay, Greg, here's your chance. Let's hear your story.
Yeah. So I get, as you do, I'm sure, and Joe does, we get these calls all the time about, hey, this patient came in. I know I call Joe on neuro stuff all the time. And so one of my friends calls me up and says, hey, I got a patient with like blood in their tears. And I'm like, all right, sure, it's not like a subconj heme. They're like, no. They said it's blood. They're coming in. I want to kind of be prepared whenever they get here. I'm like, oh my gosh. I said bilateral. Yeah, bilateral, both sides. Because I was thinking, all right, maybe a pyogenic granuloma, something like that. So like, okay, maybe a bilateral viral condition, so on and so forth. I'm like, listen, I don't know. When the patient gets there, examine them, tell me what you see, and then, give me a call back. So, because I kind of mentioned the pyogenic granuloma stuff. I said, maybe there's something up under the lid, but bilateral, I'm just like, this doesn't make sense. So they're examining the patient and they're getting ready to like flip the lids. And all of a sudden they squeeze really hard. And these fake eyelashes, I guess, were like almost like wire and like went into each eyelid, like a needle.
Oh my goodness.
And created blood, and they saw it underneath the microscope, and then it ran down like the sides and into their tears, and that was their bloody tears. So there you go.
Goodness.
So there you go. I guess these things are pretty wire-like, needle-like, popping into the skin and drawing some blood out of there. So that's my story. So
they can migrate all kinds of places. I mean, and that glue again is filled with formaldehyde, and they'll even calcify at the base of them. And because they're so heavy, sometimes you'll get lag ophthalmos. So not to mention, we talked about the collection of bacteria underneath that lash bed, and then constraints to just physical hygiene and cleaning, because they've been told to only either clean them with certain things or don't clean them at all. And then calcification of that lash base, and then the preservatives. And so I've had some wins in this category, and I've had some epic fails. I had a patient one day, after I went through the whole thing of how to clean them. I have like a whole kit on how to clean these. And she walked to the front, and I overheard her like as she's going up, and she's like, well, that's all well and good, but I better ask my lash girl what she thinks. And I'm just, like I died a little bit on the inside. And so there's lots of work for us to do in this space. So good practices are look at the glue ingredients, take breaks from them, and clean them with hypochlorous acid spray. And, the other thing when we look at this, these are easily missed if you're not like looking at it. This, we're actually looking at a patient that we were looking for Demodex, but this is a really good just practice pearl to get really comfortable and a good reminder of what can easily be missed if we're looking straight on with the patient behind the slit lamp. Because when you look at them, everything looks pretty good there on the lashes, right? But when you have the patient look down, that's what's uncovered. So just make sure that we're doing that, like on each and every patient, that we have them look down so that we're looking for, Demodex collarettes, and we're looking for misdirected and missing lashes. And then that's how you're going to see a lot of times extensions too. And you're looking at the base of those to see what's happening between the skin and their anatomic lash. So eyelash perm, lash lift, and tint, this is another big thing. And these are actually perm chemicals to create curl that they're putting on the front surface. This is an absolute no. And then permanently dyeing, and permanent dye means that should be in quotes too, because it's not permanent. It'll last about 3 to 4 weeks and they have to have this redone. But all of these chemicals can wind up on the front surface. There's multiple, case reports of corneal abrasions and chemical burns. So that one's always a no.
Hey,
And then,
Selena,
yeah.
I'm sorry, a question came through. Is there any particular hypochlorous acid spray that you recommend?
So there's tons on the market, right? And there's, Optase makes one. That one just came out. We Love Eyes is the one that I carry in my office. Dr. Tanya Gill carries that one. I mean, gosh, who else? The really good group that does.
Contamac has one. Avenova.
Thank you. They have
Avenova
one.
has one.
Avenova. There's tons.
I think they do. Yeah.
So Optase, I think, is the newest kid on the block. But now with all of those players in the space, cost has sometimes been an issue, but that no longer is the case. So eyelash serums are huge. And Latisse is the only FDA approved lash serum because its active ingredient, as we all know, is 0.03% bimatoprost, right? We all have glaucoma patients. We treat glaucoma every single day. We know what 0.03% and actually even 0.01% do to the lashes. What's hidden is the synthetic prostaglandins. Because they're synthetic, they don't have to go through the FDA process, meaning that they don't have to have any kind of label. And so you're going to look for the ingredient isopropyl cloprosinate. That's the synthetic prostaglandin. Lots of patients are doing this. And a great question to ask is when you see somebody that has, they look like they're on a glaucoma med, and we need to be asking questions. What are you putting on your lashes? Because they don't know when they're buying this from their lash girl, from their hairdresser, from whoever, because this is all over the counter and there are multiple products out there that it can cause ptosis, that it can cause periorbital fat atrophy is, of course, the big one, meibomian gland dysfunction, dermatochalasis, hyperpigmentation, and of course that long-term redness that patients get with a prostaglandin. So this is a really big question that patients need to understand, and that's the ingredient they need to look for. And so that's listed and that's in your handout. So
I got another story to tell you.
Okay, let's hear it.
So I guess my young partner in the practice, he's been treating this person for contact dermatitis. And he's like, okay, this is like, Medrol dose pack number 3, can't figure it out. So he's like, hey, can you come in and talk to the patient? So I've kind of learned to say, okay, tell me like everything that you're doing. Like, is there just any over the counter stuff, just something it might not be, you might not be thinking of, just like not like 1% hydrocortisone cream is going to do this, is going to help resolve it, but like hydrocortisone cream, like anything that you're doing. I said, lash boost from RNF. She goes, yeah, lash boost from RNF. I use it every day, or RNF or whatever it's called. And I said, look, do you know what's in that? And it's basically Lumigan, right? So we figured it out. That's what she was allergic to, and she was bummed because the guy did ask her like multiple times, "Are you doing anything?" And she just thought that since she was buying this from like a friend that was doing RNF, whatever it's called, and she thought that wasn't anything to even worry about. But it has the bimatoprost in it.
Yeah, I mean, and patients do it all the time. I mean, I make my dry eye patients in particular, I make them bring in like, I want everything that you use on your face, I want you to bring it to me and let's look at it together. Because a lot of times they just don't think about it, right? Because it's over the counter and it just doesn't occur to them that this could be the underlying culprit. And then blepharopigmentation, which is eyeliner tattooing. I have so many patients that have horrible meibomian gland dysfunction because they've killed all their meibomian glands because they did this years ago. It's impermanent because it's not. They have to have this redone every 3 to 5 years. You can get dermatitis just from the reaction to the ink, but it's really more about what we're doing mechanically to those meibomian glands when you punch that tattoo needle right through those. So that's always a no. And I've had some wins in this category. I've had some patients call and ask, hey, I want to get this done. What do you think? And I'm like, nope, absolutely not. So mascara is a $1 billion product in and of itself. And this is a big offender because a lot of times it has formaldehyde in it, iron oxides. I mean, there's been case reports of bat guano. There's all kinds of stuff in mascara. So look for clean lines. This is one, Eyes of the Story. I have no financial affiliation with this group, but this is the founder, one of the founders of TFOS. And she launched this in March of 2020. There's several others. There's another ophthalmologist that just launched 2020 Beauty. There is a company called Ocular that has some new things available. So, you know, look for things that you can recommend that have good ingredients, but do your homework and look at the ingredient list. When you have patients like this, when you see eyeliner clogged up in the meibomian glands, this is a problem. This is when people are tight lining or water lining. So here's how to the do and the don't. So for those of us who don't wear eyeliner all the time, and A is how we want to look, right? Keep it on the outside of that water line on the dry part of the skin versus B, where they're putting it right against and on top of for all of that to migrate into the meibomian glands, etc. So,
hey, Selena, can you explain the water line?
yeah, so the water line is just it's the junction between the mucus side and the keratinized skin side, right? So the wet water line is on the inside, but we know what lives right there is the meibomian glands. And so, but people don't know that when they tight line there, they're putting that right whole layer right on top of the meibomian glands. And then when they're made of bad products too, it's like a double whammy. And then, you know, here's, I love these two memes, how to do a smoky eye in 8 simple steps. And then there's me like at the bottom, close enough. And this is another just example of like how people are putting stuff on and what happens when we're not talking about these conversations. Eyes of the Story has a great mascara and a liner that liner is easy to put on. It doesn't migrate. It doesn't have bad ingredients. The mascara comes 3 in 1. So you're getting tubes that you throw away once a month, because that's the other problem, right? That people do not throw their products away fast enough. You know, and you can imagine what's growing in those mascara tubes every time you put that on your lash and then you dunk it into that nice, dark, gross, super moist environment, what's growing in there. So this just teaches people to have better habits. So there's our Ocular Surface Beauty Blunders, and that was on your sheet. You know, but how do you approach this with patients and how do you ask these questions? So these are all great ones to ask. This will be in your handouts. You know, your lashes are really long. Is that natural? And what really like triggered this for me is I was like, man, why do the dudes always have long lashes? And finally the light bulb went off and I was like, they don't always have long lashes. They just don't put junk on their lashes that destroy them over a long period of time. That's what happens. And so, you know, look for isopropyl glyphosate, ask them how they clean their extensions. If they don't have makeup on that day, ask them if they do wear it. Have these conversations with 10, 11, 12-year-olds so that they see you as the expert. Don't ever sleep in their makeup. You know, have them bring in products, you know, ask questions like, do your eyelids bother you by the end of the day? Are you tired? Do you feel like you're heavy? Do you have trouble driving at night? It's not always cataracts as your differential, right? Do you want your eyes to be more open? I love that question, especially around upneak. And we'll talk about that. And then that sunscreen question we've talked about, and observe where they place their eyeliner. So, you know, if we do all of this and we look and we're really intimidated to have this conversation and we don't bring it up, what does the patient think on the other side of the slit lamp? If we don't say anything, right? They're going to think, well, if this was bad, they would have said something. They saw it. It's fine. I'm going to continue doing what I want to do and continue sabotaging my own eye health unknowingly, right? And none of us want that. And so, you know, don't be intimidated to have these conversations. Bring those questions up. You'll be pleasantly surprised how receptive people are and how hungry they are for this kind of information, because we know it causes contact dermatitis. We know it causes blepharitis. It causes redness. I mean, look at the redness reducing drop market. It's huge. And many times it's because of the stuff we're putting on to combat, you know, the redness and causing the redness, and then contact lens intolerance, dry eye disease, and MGD. So, you know, you can take it off multiple ways. make sure you're getting it off. And this is a study that came out in September of 2020. I encourage you to go look it up and read the study and come to your own conclusions around tea tree oil. Make sure people are cleaning their makeup brushes at least weekly. And then print this out on a document to give patients. I can't even pronounce half of these words, therefore I don't want it on my face or anywhere else. And this comes back to that sunscreen question that you had, because oxybenzone also mimics estrogen, and it does show up in the bloodstream within 15 minutes. So in our sunscreens, we want titanium oxide and zinc oxide, but there's a list of offending agents. We have to teach people what to avoid. It's not super helpful to give them just like a whole line, because honestly, there's no like perfect makeup out there. There's just not. And so we have to look at ingredients and teach them what to avoid. You know, and just, I made a rat card that I hand out to patients. Those two apps are great, Think Dirty and EWG, because you can just shoot the QR code. And when you do that, then it pops up all the ingredients in that product. It'll red flag the bad ones, yellow flag, questionable, and green light the ones that are okay. So what should we be recommending? Water, water, and more water. 75% of America walks around chronically dehydrated. Salicylic acid and cleansers, hyaluronic acid, you know, attracts its own weight in water by 1,000%. So that's what you're going to find in all of the HA fillers, of course, is hyaluronic acid, but you'll also find it in topical products as well. And then coconut oil, caffeine is good, because not from the sense that it's a diuretic and it causes dehydration, but from the sense that it's a vasoconstrictor and it helps with puffiness and shrinking blood vessels. So there's our zinc oxide and titanium oxide, and then UV protection. Sleep is super, super critical. No one gets enough sleep in this country either. So this is the study that they looked at on why does skin cancer happen on the eyelids more commonly than anywhere else in the body. So as it turns out, the skin around our eyes makes up 1% of our entire skin on our body, but 5 to 10% of skin cancer happens on the lids. And when you look at 76 surgical patients that were going in and they said, hey, put your sunscreen on and let's photograph that, this is how every single patient looked, right? And so this is why that conversation is so important about sunglasses, because that part of our lids is just exposed if we don't put sunscreen there. And again, there's lists of how to talk to patients about that and what to give them. There's tons of medical grade skin products that we can carry in the office, but I would warn you, you need to do your homework here, because again, a lot of times you're paying for a label, and some of these that are the best beauty buys by Allure, I think is who does like the one that most people look at, have some really toxic ingredients. So just because it's medical grade does not mean that it is great for what's happening and ingredient wise. So do your homework. So this is a question I get a lot from patients. What about these dark circles? Can you help me with that? That honestly is one of the hardest questions to answer. I mean, I could do an entire, and I have started actually an entire lecture just on dark circles, because there's so many etiologies of why the dark circle is there. And then once we understand that, now we can start to look at treatment options. But many times it's because it's actually a hollowed out area because of birthdays, and we get shadows because the muscle atrophies, and then the bony orbit actually gets bigger too. And so you'll have like this pseudo herniation as well. And so for those patients that have that, you can do an HA filler in the tear trough area. It's off label. You can also do fractional ablative laser to rebuild collagen. So excess pigmentation, you know, post-inflammatory hyperpigmentation, melasma happens here, and then just periorbital melanosis, that can be treated with IPL. And because that targets pigment, which we're going to get into, you can do a Q-switch laser as well, and then non-ablative, because anything with a non-ablative or an ablative fractional resurfacing laser, you're going to build collagen. When you can build collagen and elastin, you're going to thicken the skin and you're going to make everything look better. And then prominent vascular. Some people just have really thin skin there and they get venous stasis underneath. That's going to be, again, you're looking at what you're actually targeting, which is blood. So that's where IPL comes in, long pulse lasers. And then there's exogenous, which we've actually talked about with the mimatoprost-induced periorbital hyperpigmentation that people get. And IPL, again, will help with that. You can also do laser resurfacing and HA fillers. So it really depends on why the circle and why the dark circle is there. So when you look at these patients, the top one, she's got volume loss. And so for her, it worked great they actually did fat transfer, which is becoming more and more common anytime they do anything in the mid face. Fat transfer. The second patient, she wound up doing laser skin resurfacing. The third patient needed a lower blepharoplasty with fat transposition because she was so hollow. And then the fourth patient, of course, has herniated fat pads forward. There's nothing you or I can do cream wise or anything else that's going to make that better. That's a surgical case. So we have to really understand why that is there, what's happening, so that we can make either an appropriate referral or make an appropriate treatment recommendation. So, we talked about redness reducing drops. We need to really understand why the redness is there. So how many people on here co-manage cataract surgery? And I'm going to pretend I can see all of you in the audience. And I'm guessing that probably 100% of the people are going to raise their hand right now. And if I ask you, how many of you co-manage your oculoplastic surgeries? I bet it's maybe 1 or 2, maybe 5, maybe 10 of you. And I think that there's a huge opportunity here for us to co-manage these patients because they're in our chairs. So let's talk about surgical cases. So ptosis is a big one. This is something that you and I see every single day. So happens that ptosis, especially acquired blepharoptosis, is actually much more common than we think. 135 million people by the year 2026 will have acquired blepharoptosis, and it starts in their 30s. So it happens a lot younger than what we realize as well. And when you start to look for it, you'll start to see it. So we have to be careful here and look for, is this new onset? Is this unilateral ptosis? If it is, we need to make sure that we're looking at pupil and that we're not missing Horner's or a third nerve palsy. Look for Frontalis Recruitment. That's where the muscle in the forehead is pulling things up. And you can see, like on this patient, she's been doing this for a while because she's made a whole new comma right above that left brow because she's been pulling that up. That tells you that that's been there a long time. So there is a drop available now with Upneek, and it's 0.1% oxymetazoline that you and I can prescribe to the patient. This is an alpha adrenergic agonist. And just to review our anatomy, there's two muscles that lift the lid, the levator and Mueller's. And Mueller's is an adrenergic receptor expression. So when you put this drop in, that's what you're activating is Mueller's muscle. And so you'll get lift with this drop, and it happens to work really quickly. You can start to see changes in about 5 minutes. Its peak is at 2 hours. I have patients do it and wait 15 minutes, and we'll have patients do just one eye. And that's what you'll see here. This is one of my patients. She's 38. This is not somebody that I would have really even had a conversation with about blepharoptosis because historically we didn't have any address with this except for surgery, right? And this is not a surgical case. And so now that we have this drop, I am much more in tune to looking at lids, and I'm asking patients, do you want your eyes to be more open? That one question drives this whole conversation. And this was a patient that she had bleph surgery several years ago, and she just didn't want to have it again. She's like, I had a good result. I'm happy with it. But man, if I could just get a little bit more lift, I would love that. And so we did this on her. This is 15 minutes, and she was thrilled. And so I always have the patient just do the right eye. So because it's relative, right? If they do both, it's harder to see the difference. And so I have them just do one eye. And if they love the way that they look, then we treat the other eye so that they're balanced. But Mueller's muscle repair is a longer term solution. This is when you have ptosis with good levator function. Most oculoplastic surgeons are either doing a 2.5% to a 10% phenylephrine test because, again, we're activating Mueller's muscle to see, is this the problem? And you can tell when you do that photo flash and you're looking at that MRD1 that, this patient has definitely got MRD1 that's less than 1 millimeter. And so when it's positive, then we're just shortening Mueller's muscle. So it tells you what kind of surgery we may need. So
I'm going to let you take a breath there because you lecture on this, I lecture on this, but I bet you there's a few people out there that don't know what MRD means.
I have a good schematic that's coming up.
Okay. So just be careful of that. And I'm gonna let you take a breath there. I want to make sure we answer the hypochlorous acid question. They asked if we recommend any. I don't really recommend any. We listed off a bunch. Remember that hypochlorous acid comes from a white blood cell. Whenever you get an infection, it's naturally produced. They just take that natural product, put it in a bottle, or they make it synthetically. But since it's natural, it can't be patented. So that's why a lot of people can make it, because that's just a natural product that is found in nature. And then the other one that I want to point out, then I have a comment on Upneek for you. But it's someone asked a question. Are you saying the isopropyl prochlorestine is a good thing or a bad thing?
It's a bad thing in a sense that patients don't know what they're putting on. So when you and I all know what that can do to my meibomian glands. So do I have patients that I prescribe Latisse to? I do, but I do a baseline of their meibomian glands, and I manage that way. So that if we start to see changes, then we're going to have a different conversation around what we're doing to lashes to get lash growth. So isopropyl chlorplastinate is one of those ingredients that can be hidden that can cause problems that you and your patient aren't aware are causing problems until it's too late. So it's a bad ingredient. It's an offender. So I would put that on the list of things to look for and avoid.
And then my comment on the Upneek is I've been blown away by how many people are pleasantly surprised by it. I'm in Altoona, Pennsylvania, 2 hours from Pittsburgh, kind of a rural area. And you get these people coming in with, like you said, that little bit of, levator disinsertion maybe, or just a little bit of ptosis, and you put a drop in one eye. Because I'm like, hey, I'm a lecturer and I'd like to get some slides and just want to see. And they're blown away by how they look. 1 millimeter, half a millimeter, 2 millimeters, 3 millimeters, and they are super, super excited. So I guess I would say to the audience, find your rep and get some samples in your practice. And I think you'll be pleasantly surprised, because guys and ladies, they like those eyes to be open.
Yeah. I had a patient that, don't disqualify people. I had a patient, he was in his early 60s. And he's like, Selina, I really would like my eyes to be more open. He's like, I'm single. I want to look better. And he's like a big burly dude that rides a motorcycle. He just wouldn't be like the typical person that I would think about. And so it's really important not to disqualify people. I love that question and we have it on our entrance questionnaire. Would you like your eyes to be more open? And when they answer yes to that, which a lot of people do, then we just offer it then. So this is a really neat way to start to get into this whole conversation. And Upneek is bringing that kind of really forward and front and center for us. So think about too, when you're doing multiple surgeries. So I have lots of patients that need cataract surgery and they need a bleph. Always do your cataract surgery first, make that referral, get them through that, and then do the blepharoplasty. Because when they put the speculum in for cataract surgery, you can damage the levator, and you don't want to undo all of that hard work that your oculoplastic surgeon just did. So just order matters when you're doing these consults. Do cataract surgery first, then their bleph. Dermatochalasis, of course, upper lid evaluation is where we're looking for this. And there's a difference between ptosis and acquired blepharoptosis and dermatochalasis. And sometimes it's hard, they'll have both. And so that's the other thing, Upneek is on label for acquired blepharoptosis, but if they've also got dermatochalasis, it can definitely still help. It's just, they actually have two disease processes happening. So when you're looking for this, again, look for that frontalis recruitment. We're going to get into muscles here in a second and we'll review anatomy. But, check their eyebrow position, because a lot of times, either those eyebrows are tattooed on, painted on, drawn on, and their brow is like actually fallen. So it's, underneath that supraorbital rim. And that's going to be a bigger surgery. We're going to need a brow lift in addition to their dermatochalasis. And then look for herniated fat pads. You can even have, the lacrimal gland can move out. This is a patient with dermatochalasis, and she's actually got a little bit of brow ptosis too, but it's hard to tell because she doesn't have any eyebrows, right? So that's why it's so important to like look and feel. It's not enough to just look. You have to look and feel like where things are and where the anatomy sits. That's a little unusual for us. We're not used to like really touching patients all the time on their face, but you'll have to do that to get, understand what's happening with the anatomy. So this is a patient that came in for her regular eye exam, and she has this like funny head tilt like this. And that's the biggest pearl I can give you tonight is when you walk into the room, always look at how the patient sits, look at their posture, look for, funny head tilts like this, look for any like weird head tilt side to side. You'll miss stuff if you don't. If you come in and like, that's what I teach all my students. I'm like, don't come in and dive right into the EHR. Take a step back, have a conversation with the patient face to face so that you appreciate all of the things. And so when I started talking to her about this and I set her back up and like moved her chin down and then lifted her lids up, and she's like, oh my goodness, my eyes, like I can see. And she'd had a lot of neck trouble. She was at the chiropractor every week. So this will cause problems other places because of these funny head tilts that patients adapt. And again, this is a patient that came in for her annual eye exam. She was not there complaining about her lids, and very few patients complain about their lids. We really have to ask these questions. This is a patient that he was actually a referral, but he kept getting like these little skin infections in that lid because it's not getting any oxygen, right? And his brow is fallen. When you push up underneath there, that definitely is tipped forward. You can see those commas that he's made when he's pulling that up. And what I mean by comma is those little, it looks just like a comma above his brow, that little wrinkle that people get because they're using that frontalis to pull everything up. So dermatochalasis, and this is a patient that's got herniated fat pads as well. She's got, a lower lid blepharoplasty would be what we need here to address the lowers. And then upper, you can tell that she's been really cranking out on that left side. Look at that huge comma wrinkle that she's made, pulling those lids up out of her way. And I can guarantee you she's tired by the end of the day. That's a functional patient.
So Selina, before we get too far away, there's some questions that came in through the chat box.
Okay.
And the first is, how frequently can people use Upneek?
How quickly?
How frequently?
Oh, frequently. So it's a once a day drop that they can use every day if they choose. And in the studies, it was measured at 42 days and there was no tachyphylaxis that happened in those 42 days. So I have patients that use it every single day, but on label, it's QD dosing in the tonic eye, which may be both. And they stopped measuring at 6 hours, but it can last longer than that. That's just the last endpoint that they measured in the clinical trials. So it can be something that the patient uses every day.
And what are the systemic contraindications to using Upneek?
There are none, so there are no contraindications with the drop. But when you look at alpha adrenergic as a class, just like we would with like brimonidine, that's an alpha adrenergic as well. We have to look at it as a class. So when you look at that class of drugs, it can cause some problems with vascular insufficiency. So if you've got patients with uncontrolled hypo or hypertension, then be careful there. But in the studies, there were no contraindications. Just we need to look at that class of drugs, just like we would for a glaucoma patient. Same class, right, with alpha adrenergics. We need to look at hypertension, and then patients with Sjogren's, not in the dry eye sense, but their vascular insufficiency that can happen with Sjogren's is another risk. So patients that are uncontrolled, high blood pressure, high or low blood pressure, I would avoid.
Hey, Selina. Hey, Joe, hold on 1 second. And the vial has, as any medication out there, to be overfilled. So in a few patients, they put it in early in the morning. I just have them save the extra drop or two. And if they want to put it in the second part of the day, that's fine. We're so used to doing dinner programs and so needing to stay on label. So yeah, we can talk off label here. So they can use that second drop in the evening. That's not everyone that needs to do that, but just remember that. And then the other part is I have the privilege of lecturing with Dr. Tracy Offerdahl out there. And I was chatting, she's a PharmD, she's a pharmacist. She teaches at Salis. She's been on our programs, live programs, and on these webinars multiple times. And I asked her about that same question, and she said, anytime you have an alpha adrenergic agonist, automatically, boom, they slap that, hypertension, Sjogren's right on there. And she looked at this molecule and she saw how small percentage, and putting it as an eye drop. She goes, you can never say never and never can say always, but your risk of something like that happening with a topical medication at that percentage is going to be very, very small. So just be aware of it.
What kind of effects does IP cause? That was another question.
What kind of effects does what?
IP.
Like, I don't know if I know what they're asking.
Yeah, let me see if I can find the question and maybe help you out here.
While you do that, another question is, what are your thoughts on Zoria Boost Eyelash Serum from Ocusoft, which is non-strict?
Look at the ingredients really closely. And go through and look at and see if there's any of those ingredients that show up in that one. But pull that slide whenever the deck comes and look at the ingredients on it.
And going back to the question, it was isopropyl. Yeah, not IP.
Oh,
IC.
I see. So that one is mimicking a prostaglandin. So we just have to be really careful. Can patients use it? Yes, but they need to keep it off of their skin. And I do a baseline meibography so that we are measuring and we're making sure that we're not causing meibomian gland dysfunction, which is a well-known complication with a prostaglandin.
That's it, I think.
Okay, so Frontalis Recruitment, which is something that we're not usually typically looking for activating, but this is important when you start looking at, okay, what are we actually going to refer the patient for? And so this is a patient that came in, again, he came in for his annual eye exam, no complaints, nothing about lids, right? And so I reach over and I make him I force him to push all this down. So the picture on the left is him in normal gaze. And then after I pushed all that down and made him relax all those muscles, look how much heavier that is, right? I mean, I don't know how he sees at night, and I'm sure he's super tired. And so when you have patients and you're looking, do they need a brow lift? Do they need dermatochalasis? Do they need a blepharoplasty? It's helpful to know where those brows are and how much frontalis recruitment you're having. And when you put a finger right here above that eyebrow and you hold that, patients can't use that frontalis to pull that lid back up. That's also another way that you can measure that. So just a couple of things that we're not typically used to measuring. And to fix that, of course, surgically, we've got blepharoplasty, which is considered cosmetic, and we're taking off that excess skin and we're making an excision there. And then we're basically just suturing that back together. We may reposition orbital fat. And then functional blepharoptosis is when we've got a patient like him where we've got, vision blocked by those droopy lids. It's almost always going to be covered by insurance. So here's that question of, okay, how do we actually measure what MRD1 is, which is our margin reflex distance? So how do we know if insurance is going to cover this? And it's going to be different by payer, and it's going to be different by region. So I'm in Oklahoma, so my payer is Novitas on Medicare. And so this is their guidelines currently. A normal MRD1 is going to be 4 millimeters. And interestingly enough, when you look at how many people have less than that, like 30% of 30-year-olds have 3 millimeters and less. So it's much more common than we realize. So if that upper lid rests at 2.5 millimeters, and what the MRD is measuring is that light reflex from the center of the pupil to the edge of the lid. So that's your MRD1 on the upper. MRD2 is when you're measuring from that light reflex to the lower lid. But in all of these, and with most insurance companies, you're looking at that MRD1. And so in our region, it's 2.5 millimeters or less from the light reflex, and their visual field has to be affected. Or if you've got lash touch and their MRD is less than 1 and they've got symptoms, then insurance is going to cover that. So that's a good little schematic on how to measure MRD1. And there's a good image of that nice light reflex. And so you would just use your little ruler to measure that MRD to the edge of her lash. But she's got lash touch, right? She's got skin touching lashes. That would qualify her where I live. So there's lots of pieces here that you and I can do. And, that's an office visit. We can do visual fields. It just depends on your oculoplastic surgeon and that relationship that you have, et cetera. And so my oculoplastic surgeon and I have a very close working relationship. He hates cosmetic stuff. So he pushes like cosmetic Botox and all that kind of stuff to me. He likes doing nothing but functional, and he's amazing. And so we have a really good relationship together. We're in different practices, but those are the kinds of relationships that you want to build with people in your area that are receptive to that. And you'll keep asking, and you'll find somebody. Make sure that we wait 4 weeks post-bleph to do a refraction for their glasses, because it will actually change. So we've talked a ton about upper lid. We cannot forget about the lower lids. We're looking for scleral show. We're looking for ectropion, puncta position. Do they have epiphora because their puncta is misaligned? Telangiectasias, that's going to come in. Those are those little red blood vessels that are crawling over the eyelid. That's going to come into when we talk about IPL and what's happening with dry eye disease and meibomian gland dysfunction. Lumps or bumps, follow that ABCD rule of asymmetry, borders, color, and diameter. And then of course, loss of the hair follicle. And then make sure you're looking for blepharitis. There's a new molecule coming to market, probably early 2023 would be my guess. It's called TP03, and it completely eradicates Demodex over a 6-week period. So stay tuned and start looking for this in your patients, because that is another disease state that is so common that you and I have gotten used to seeing that all the time. And because we're relying on patients to be compliant with the things that you and I recommend, sometimes we can get numb to that. So start, when you're looking at patients, make sure that you have them close their eyes and look down so that you can look at the base of those lashes. And then pull on those lids. Are they floppy? What's that snap test look like? Malar hypoplasia is this cheekbone right here starts to fade and flatten as patients have more birthdays. That can cause problems with ectropion because there's no scaffolding there to literally hold that skin up.
Selina, before you get too deep in from the upper lid, and yes. I just want your thoughts on this, because obviously I used to work with an oculoplastics person, I don't know, for about 3 years, which was fun and kind of taught me a lot of this stuff. And in moving that upper eyelid out of the way, just, I think a lot of our docs think that you're just kind of moving a big piece of lid, which then opens up the visual field. But my thoughts also are, and I'd like to get your thoughts on this, is, we move the laser peripheral odotomy from being superior because of the tear prism. And, we now kind of put it at, I guess, 3 o'clock or 6 o'clock or at 9 o'clock. You do lasers in Oklahoma. I don't. And you probably have a better feel on that. But my point is, when you move them, we're talking about that marginal reflex distance and moving that upper lid out. And I get patients that get much better acuity also. And I think it's because also moving that tear prism. What's your thoughts on that?
It's tear prism and it's contrast sensitivity. And there's actually a study on patients that had blepharoplasty. And it wasn't just that their visual acuity improved, it was the quality of their vision improved as well. And that was a really good study. So you're exactly right. It's actually both. It's vision and the quality of the type of vision they have.
Thank you. Thank you.
Yeah, absolutely. So when we look at ectropion, we can have congenital, cicatricial, mechanical, and involutional. What typically we're dealing with is the kind that we get from birthdays. And then an easy fix to this is a lateral strip let's say that 3 times fast. A lateral strip tarsorrhaphy of the lower lid. And we're going in there and we're tightening that. And where I live, insurance will actually pay for that with simply artificial tear failure. But there's no amount of help we're going to be able to give this patient until we get that lid structurally where it needs to be. So lower lid blepharoplasties, there's 2 approaches. And, depending on what study you read, there's different ways to handle this too. And fat transfer has become a big part of this conversation into, places you want it to be and removing it places that you don't. And so transconjunctival is one approach. Transcutaneous is another approach. If you've got fat herniation, they'll combine it with laser resurfacing because you're typically going to leave like a little scar. But there's lots of different approaches there. But here's what my oculoplastic surgeon has taught me. He says that upper lid blepharoplasties, almost every patient is really happy with their result. Lower lid blepharoplasties are a lot tougher. About 80% of patients are going to be really happy with their result. You know, that's a challenging part of the skin. The skin there is thin, the anatomy is different. It's just not very forgiving. And so just know that and set proper expectations with patients when you send them for those kinds of referrals. And then if they're going to have a brow lift, which a lot of patients need in conjunction with their dermatochalasis surgery and their blepharoplasty, endoscopically direct approach just depends on what's happening and what your surgeon is comfortable with and how they want to handle it. Most of the time, my surgeon's doing an endoscopic brow lift. So he's pulling all of this down and then pulling it all back up, and he's putting fixation posts underneath the hairline. So there's no visible incision, which is great. Those little posts will last about 6 months and then they start to dissolve. And then a browpexy is when they elevate and stabilize that brow because they're fixating that to the underlying periosteum. And they're doing that typically with an upper blepharoplasty. The other take home to this is none of this is forever. So 5 to 10 years is what this is going to last. And then patients may need a revision. So again, setting proper expectations is really key here. And then we talked about lumps and bumps. 90% of basal cell carcinoma happens to be on the left lower lid. This is one of my little patients that is a retired pilot. He came in with a new bump on his left lower lid. And he said, it just popped up yesterday. And honestly, when I looked at it, I really thought it was a teeny tiny, like just little hordeolum. Like it didn't match any of the ABCD rules. And so I put him on heat therapy. And we did, I think, a steroid combination for a week, and I brought him back and it looked exactly the same. And it just, I don't know, I just didn't like it. And, you know, that sixth sense that you sometimes get that you should never ignore because it's always dead on. And so I sent him out, and this was how much tissue they had to take to get clear borders. So you just never know until honestly you remove it. But any kind of, and he wound up doing fantastic, but he's a hoot, and he's like, put me in your slide deck, Selina, please. And I was like, okay, done. So just make sure.
Would that be a Mohs procedure then when you said clear borders?
Yeah, that was a Mohs.
Okay. So just so people know, what they do is they work in conjunction at the same time with a pathologist, right? When they do
Correct.
that surgery?
So the pathologist will be outside of the room. And so they just they'll cut, and then they'll send that. The pathologist looks at it, and they'll just keep cutting until we get clear borders so that you're not having to go back and get tissue. The patient's already right there. And you'll have lots of, I mean, I had a Mohs procedure on the back of my left leg, a spot that looked just not right. And sure enough, it was not right. And so they did 5 centimeter borders, and while I was sitting there, and everything was fine, but that's what they'll do with the Mohs procedure. Don't ignore lumps and bumps. So let's switch gears. We've been talking about surgical, and we've been talking more functional. So let's talk about and wrap up our last 30 minutes here with what is beauty really considered, and how can we enhance and do things to the face and the body too, but we're going to talk about the face with things that you and I can do to help turn back the clock or keep the clock where we want it to be. So one of the things that we really have to understand is the face and like the 3-dimensional plane, and who is considered beautiful and why, and what people aspire to be. And we touched on that a little bit with our Disney princesses, but Hollywood is the best place to look at this because you can just sit and study pictures, right? And I love having Tom Brady on here because he and I happen to be the same age. So when I want to feel really bad about myself, I just think about him, and wow, he won like the 7th Super Bowl at 44, and I might throw my back out brushing my teeth the wrong way. But Hollywood is a great place to look at faces and start to study that, because why are people considered beautiful? And the answer to that is symmetry. So symmetry is what is considered beauty. There's a whole golden circle, but it really comes back to symmetry. So when you look at these pictures, the original is on the left, but if you dissect someone right down the midline of their face and you compare their right side to the right side and the left to the left, the more symmetrical they are, typically the more they are considered beautiful. So Carly Kloss is supermodel. She's not perfectly symmetric, but she's pretty close. Holly Berry, I think of all of the photos that I've pulled, she is the most symmetric person I have ever seen. It's really difficult to tell which one of those is really her. Gwen Stefani, I like to point out because we've got eyebrow symmetry that comes into this, because 90% of us walk around with one eyebrow higher than the other one, and no one is more critical of their face until they have something done. So that's why pre-photographs are so important. And then you need to have a conversation around this too, especially if you're doing neurotoxin. And it's really easy to tell which one of these is her because her right eyebrow is higher than the left. And so I teach my patients the two sides of our faces are sisters, not twins. We're not perfectly symmetrical. Gigi Hadid, Bradley Cooper, and then Ryan Gosling is a great one to like just look at and go, okay, which one of those is really him? And once you start looking at that, it's really easy to tell that the middle one is him because his right eyebrow is higher than the left. Like he's just not perfectly symmetrical. And then Tom Cruise is my favorite because once you see this, you can't unsee it. But this is a good example of why symmetry really matters the closer to the center part of the face and the closer to the midline of the face. The further you get away from that, the less it matters. So think about Cindy Crawford, and I've got a good picture of her later. But, you know, I grew up in the 90s. She was a huge supermodel back then, and she had this really distinct mole right above her lip. And that was like her signature, right? I mean, I remember like painting on a mole to like mimic her. And I can promise you her career is way different if that mole happens to be like right on the end of her nose, right? That signature look goes from being a signature supermodel to not getting on the runway with that. So symmetry matters, but the further you get away from the midline, it matters less. So let's talk about anatomy and age and what happens. We get UV exposure. Photo damage is so causative of how we look and what happens to the skin because we get free radicals. Sunscreen, and more sunscreen. Gravity, loss of collagen, loss of elasticity, and our skin thins. So that's why we age. We lose that. We start losing it at the age of 35. Women lose it faster than men, and we get damage from the environment, from UV, from smoking, from autoimmune diseases can also do that. But we've had this big shift in the plastics world from radical reconstruction with surgery to, okay, what can we do with energy-based devices to utilize natural processes to restore and reverse the signs of aging? Because our body is capable of doing that, but we have to do things to it to make it do that and stimulate those processes to happen. And it just so happens that you and I can do a lot of these. So understanding how the face ages, I love this example because this is mother and daughter, and they've got the same bone structure, but you can see what happens with birthdays, lines and wrinkles, skin starts to droop, things start to migrate lower. We get sagging on that jawline. The fat pads actually move and herniate different places. That's why you get that nasolabial fold and why you get that tear trough underneath. And so we lose that fullness and that flattened cheek. Remember, I talked about malar hypoplasia because that fat pad actually starts to atrophy. And so we'll talk about how to address that. Muscle atrophy happens, and then the bony orbit actually gets larger. Another reason that this area and dark circles happen. And then we lose bone mass. And so all of those things contribute to that. So our goal with each of these modalities that we're going to talk about is to repair damaged skin. We're going to eliminate laxity, and we're going to restore that youthful volume. And this is a fun little like face app that you can do. That's me on the upper left, upper right, me in 10 years. Filter lower left. And then for some reason, when I have a Y chromosome, I lose all my hair. I don't really understand that, but you know, hey, whatever. But what's really sad and scary is people are now coming into plastic surgeons with the filters. So that bottom left picture, they're showing up with filters and saying, I want you to make me look like this. And so we have these ridiculous, unrealistic expectations. And so that also needs to be part of this conversation. Groupon vouchers, charge what you're worth in this. Do not do this. And always a hard no on Groupon vouchers for anything aesthetics. So here's our new poll question. What percent of our patients that you and I see on average do we think are having neurotoxin done? And neurotoxin is Botox, Xeomin, Jeuveau's the new kid on the block, and Galderma's product, Dysport, is the other one that's commercially available. So what percent of our patients in the US do you think are having neurotoxin done? 10, 20, 40, 60%. See what you guys think.
Yep, rolling in nicely here, just so you know.
Good. And the really cool thing about neuromodulators, this was founded in eye care, right? This was an accident, like so many things are in medicine. So they started treating it for blepharospasm and strabismus. And when they were treating blepharospasm, they just noticed, hey, by the way, my wrinkles look better. And the ophthalmologist that was doing it sold it to Allergan for a penny on the dollar, and Botox was born. So 10%, 28%, 20% said 41, 40%, 60%. So when you look at the fact that we're doing about 88 million comprehensive eye exams a year, and there's about 8 million injections, about 10% of our patients. And so this comes into play because, and depending on your area, it might be more than that. Patients are doing this, and if you get real aggressive in this crow's feet area, you're going to mess with the blink reflex, and it will cause problems with dry eye, or cause dry eye, or sabotage your best efforts. So these are conversations that we do need to have. Even if you never inject ever, perfectly okay. I'm going to walk you through some case reports on why and how you should know this. So we talked about the different types, but we're using neuromodulators to reduce and eliminate fine lines and wrinkles because we're temporarily preventing the muscle contraction. So what does that mean? And I got really heavy into this. Let me tell you my story, because it's important. And it goes back to my why of the things that we do. So when I started doing this, I looked at, and I'm in Oklahoma, but this was not in our law. Our law is exclusionary, and it says you can't do LASIK, you can't do retina surgery, and you can't do cosmetic lid surgery. And I was like, injections aren't surgery, so we should be able to do this. So it took me about 6 months to convince our board that this was within our scope of practice. Once that was accomplished, then I was like, great, I got to find somebody to train me on how to do this. So I enrolled in a class, a weekend course. There was 30 people in the course. They barely let me come, only because I paid money, but I've been kicked out of as many of these as I've been to because I'm an OD. And anyway, I was there with nurse practitioners, RNs, a lot of dentists, but there were several ER doctors, family medicine doctors, and there was a young woman on the front row. I'll never forget it. She was an MD. She'd passed her boards the night before. And so everybody was like celebrating, as they should. If she was like me, that was the smartest I was ever going to be before like stuff started trickling out. And the proctor knew this. And so when he starts getting into muscles, he asked her, he said, hey, you just passed your boards the night before. What's the muscle around the eye? What's the name of it? And what's its action? And you can imagine what she said. She's like, I have no idea. We don't do anything with the eye in medical school. We certainly don't do anything with the muscles. How would I know that? And I, like, the skin on, like the hair on the back of my neck just went, Erk. And I was like, wow, I'm the most qualified person in this room to be doing this, because it's the orbicularis oculi and it's a depressor. So once I kind of heard that, it just even more so made me want to put this into optometry's hands, because you and I are the most qualified persons to be doing this. So let's review anatomy. So we talked about the frontalis muscle. That's that muscle that runs all the way here to the top of the brow. That is the only elevator in the forehead. What happens when you paralyze an elevator? You get depression. This muscle here in the middle is the procerus. The corrugators run right underneath it. And then, of course, you guys all know the orbicularis oculi, and it's a depressor. The procerus, as well as the corrugators, all depressors. So when you paralyze the depressor, you get elevation. Once you know the action and you know how to manipulate those muscles, you can start to get the looks that you want. Start studying faces. Again, Hollywood is a great place to do that. Grocery store line, checking in at a hotel, all those places are great places to look at faces and study expressions and how people move their face. Men are easier to learn because their muscles are bigger. They're easier to feel and know where you are. And then you have to remember, and if you don't follow Celeste Barber, I highly encourage you do so, because she takes all of these nonsense photos that people compare themselves to that are completely unrealistic and totally photoshopped, and then recreates them in real life. And she's fantastic. She's an Australian comedian. But anyway, Celeste Barber, if you want a good laugh. And she makes great fun of the Kardashians, which I absolutely love. So neurotoxin is for dynamic wrinkles, meaning those form during the contraction of that underlying muscle. So here's one of my patients who had an injury when he was 17, and it damaged his 7th nerve. So what do we see here on one side of his forehead versus the other? And this goes back to how that blepharospasm piece came out, right? So when you can't contract that muscle, the wrinkle doesn't form, right? That side of his forehead is super smooth. That's what he's doing when he's elevating it. So he's lived like this his whole life, but you can see why this works so well for patients that have wrinkles, and then also to do what we call prejuvenation before somebody gets a wrinkle. And then another example, this is an OD that had jaw surgery, and they damaged her 7th nerve during her jaw surgery. Same thing, she can't move that right side of her forehead, so she doesn't have any wrinkles over there. So we do Botox on that left side of her so that it matches. And then this is a patient that came in. So for those of you that have zero desire to ever do Botox or do an injection, totally okay. This is a patient that showed up in my clinic for a glasses recheck. And I looked at her history and I was like, well, that's weird. She got her glasses like 4 months ago, but all of a sudden she's having trouble with her glasses. And so I'm looking at her review of systems and she's got chronic migraines. And I was like, And I'm looking at her face and I was like, anything different? What are you doing for your migraines? And she said, oh, I got Botox like a month ago. And I was like, oh, really? Where'd all, like, in your head for the chronic migraines? And she's like, yes. And I was like, So when did the glasses problem start? Oh, about 2 weeks ago. So what you notice on her is she's got a teeny tiny forehead. I mean, it's tiny, like 1 finger, right? I have like a 5-finger forehead. Like there's a lot of real estate up here to do some things with. She does not have that. So when they do migraine injections, they inject in the hairline and they inject a lot of Botox, like 150 units. Typically in a forehead, I'm only going to put 25 to 50 units. So they completely froze her. This picture is her trying as hard as she can to lift her forehead. So this is from her Botox. And so I reached over with her glasses on and I pulled those lids up out of the way. And I was like, does that help? And she's like, oh my gosh, it's like it used to be. So we would have spun our wheels doing a refraction when it in fact was actually from her neurotoxin that's going to wear off in 90 days, which she was fretting about because she didn't understand that it was going to wear off. And so she was greatly relieved to hear that. But this is the kind of stuff that will show up in your clinic. This is a patient that did come in asking for, he wanted a brow lift. And I was like, well, let's talk about how much Botox you're putting in your forehead first, because remember, when you put a ton of Botox in your forehead, that's our only elevator, right? So if you paralyze your elevator, you get depression. And if you're really aggressive with that, you cause brow ptosis. So you have to stay super high in the forehead is the hallmark there. But those are the kinds of patients that will show up on your schedule if we're not in tune to this. And when you're doing this, you stay super high, you do multiple sites right where the wrinkles are. Those are the patterns, it's going to be individual to the patient, but those are the types of patterns that I do. In the glabella, it's typically going to be 3 injections right in the procerus, 2 in the corrugators, and then 2 more in the corrugators if you've got somebody that's got a really heavy, big corrugator muscle. So you can do a lovely chemical brow lift like I did on her. Like she's just got this like little pop, right? Because we paralyzed that depressor in her procerus and her corrugators and gave her just like that little bit of lift. The other thing that we did for her is because she's got really bad dry eye is we're doing IPL on her, and you can see how much better her cheeks look too. And I'll show you up close of that we did. But these chemical brow lifts are a lot of fun to do. I like this picture because it's good for anatomy. You're seeing like the striations of the frontalis muscle pulling in. You're seeing where the belly of that corrugator ends. That's the kind of stuff that you want to start looking for and looking at. This is a person that sits at my front office greeting patients, right? So this is not the best look when you have someone greeting patients. And this is what patients will express to you. People come up to me and they're like, are you angry? Like, are you mad? What's happening today? Are you sad? And nobody wants that feedback, right? That there's no better way to ruin your day than somebody walking up to you going, oh, do you feel good today? Are you okay? Did you, you know, it just ruins the whole rest of the day. And so for her, we, you know, do the same thing. We do Proceris in her corrugators, and we get that beautiful look, and she can't frowny face like that, which, by the way, her baby picture at a month old had that exact same frown. Like, she just has a lot of muscle there. And we talked about brows being definitely trendy, right? This is an example of that. Flat brow, thin brow. Now we want angled and arched. So this changes. Lateral rhytids, this is where we have to be careful, because if we get real aggressive in here, we're going to change the blink reflex. And these are questions that we should be asking our dry eye patients. Are you having Botox done? Because if we are, we probably need to rethink that in the lateral rhytids. So patients are going to have a full fan pattern, meaning they're going to have wrinkles from top to bottom. Then you'll have patients with lower fan, central fan, and you're just looking at where those wrinkles are. That's all going to be 30%, 30%, and 30%. The upper fans are going to be about 10%. Just depends on where that muscle movement is. That's where you're going to inject. And it's a really thin muscle, so you don't have to go super deep. It's all of these are, again, intramuscular injections, but again, look at faces, study faces. This is off-label. I don't do this very often. For this jelly roll look, you can, it's a really conservative treatment. It's just 2 units underneath that lid, but you can induce ectropion and lag ophthalmos really easily. If you've got somebody with a lax lid, you've got to do that snap test, and they're probably going to bruise because there's a ton of blood vessels that live right there. And again, just looking at faces. So Mephisto sign is what people will get. I did not do this to her, by the way. This was an MD that actually injected her. And we get that Spock look where you've got this, you know, upside down V that does not look attractive. We do not want to do that. The reason that that happens is because the lateral part of our eyebrows are also the strongest where the frontalis is. So to fix this, and this happens a lot actually with patients that are doing migraine treatment, because they tend to do so much up here in the top of the forehead, they don't do as much on this lateral outside edge. And those red circles are how you fix that, because when you put 2 units in there, you're paralyzing that elevator at the strongest point, so that brow drops back to where it should be. And then this is where the art and the science of neurotoxin comes in. You don't want frozen, but you have to treat people completely, or you don't get the look that you want either. And so this is just going to take a lot of practice, and, you know, practicing with the same face too. Like, it will usually take me, that's a challenge with Botox because it doesn't show up for 2 weeks, right? So you inject and you wait 2 weeks and then you look at it, and it'll wear off in 90 days. And so the awesome thing about this is when you get this consistent and you like the way things look, patients do too, and they're coming to you every 90 days for this treatment, which is super fun. Just for the sake of time, I'm not going to spend a ton of time on the male eyebrow. Just know that we don't want to feminize men. And the way not to do that is not to make things peaky, and we don't want to see lid crease on men. So with him, you know, I just popped his brow up a little bit. He's still got movement, but he's still flat, and we don't have a ton of lid crease. So I still have patients that say, when I refer them for a blepharoplasty, they're like, okay, I'm open to this, but please don't make me look like Kenny Rogers, God rest his soul. And why does this bother us so much, though? That's the key to this conversation is, okay, but why? Why does this not look good? Well, when you look at him, we've got that like surprised look. That's one thing that we don't like. But the other piece that we really don't like about this is we see his lid crease. So in men, they have a much shorter lid crease, and we don't see that, but we feminized him. We made him look like a woman. That's why this bothers us so much. So in summary of all of that, we have to become astute observers in all things eyes. That's how we get good at this. That's how we're able to have these kinds of conversations, just by looking. Okay, so fillers are for adynamic wrinkles, meaning they see them at rest. So this is where we're adding volume. There's different types. Hyaluronic acid is the most common. It can be reversed with hyaluronidase. There's polyl lactic acid, which is Sculptra, and there's calcium hydroxyapatite, which is Radiesse. And calcium hydroxyapatite also happens to be the same material that we use in implants. So if you've ever had a patient that had an enucleation for any unfortunate event, that is what they use in their implant, because it's very, it will allow vascularization, and it will allow the muscles to be reattached to that implant, so that when they do their prosthesis, things look much more natural. So just a crossover into what we do every day. Tear trough is a big one that people ask me about. I don't do these. This is off label. It's really hard to do. You can blind somebody because you can get a vascular occlusion. I recommend that we do other things, and this would be a last resort to put filler there. This is a 52-year-old female, and she had this lower eyelid swelling, and she had never had it in her tear trough, but she had had HA fillers in her cheek, and this migrated and looked like this. So after hyaluronidase, definitely it flattened all back out and dissolved, and then she wound up going on to have laser resurfacing to further smooth that out. And then this patient was the same thing. So just because they don't have it in the tear trough doesn't mean it can't migrate to places like tear trough, and now we've got puffiness. So history is really big here, because you want to make sure that you're, again, referring for the right type of thing. So any kind of history or fillers is really important. And they look really good. Cindy Crawford did make it in here. They look really good when they're done really well. I mean, the liquid facelift is kind of the new big thing, but it's expensive. I mean, when you're putting 8 to 10 to 12 syringes in someone's face, and our cost is between $600 and $1,000 a syringe, it gets expensive quickly, and it lasts anywhere from 6 months to 24 months, depending on how the hyaluronic acid is cross-hatched and which filler you're using. So too much is definitely too much, and Lacerina is too much. PRP is basically the autologous serum for the face. They're using it in conjunction when they make either little holes in the face with like a 1540. So if they're doing like a skin pin, also we'll do it with this, with microneedling. And that is one way to add effects as far as platelet-rich plasma. They also inject this. So they use it a lot for actually hair loss and injections. It doesn't last very long if you're using it as a filler, only about 6 months. So again, become an astute observer. I've got a quick poll on this next one. So we'll throw that one up. And then I'm going to have to talk fast because we've still got IPL, laser, and RF to do in 10 minutes. So is IPL a laser form of light? Yes or no? What do you guys think?
They're rolling in nicely here.
I love it.
No other questions? Comment, I live in Miami. My answer might be everyone. So.
I went to Irvine for a meeting. It's the first time I'd ever been to Irvine. And I'm pretty sure, I mean, I hate to be like stereotypical, but wow, like everyone. I saw more acrylic heels than I'd ever seen in my whole life. I didn't even know they made those. I thought that was just like in a magazine.
I think the next time that I see you at a meeting, I'm going to be wearing a mask over my face. You're going to be looking at my eyebrows.
I'll be looking at your face, like, what's happening?
I'll be talking to you with my fans over my face. Greg, what's the matter?
No.
Quit looking at my symmetry.
Okay, I love that we asked this question because IPL is not a laser. So I'm super glad that we're going to have this conversation. So there's different variation of skin devices. There are lasers, both ablative and non-ablative. Ablative means that you're removing skin. Non-ablative means that you are making micro wounds in the skin, but you're leaving skin intact around it. So IPL is actually intense pulse light. It's light therapy. We're using lots of different light energies to get the look and achieve what we want to, but it's not a laser. Super important when you're talking to your board, when you're talking to patients, when you're talking to anyone, IPL is not a laser. Radio frequency is the other one we'll talk about. It's a non-ablative device. And then ultrasound, I don't have any experience with, and it does skin tightening and collagen remodeling, but because I don't have experience with it, I just listed it here. So IPL is non-monochromatic. We're using about 500 nanometers up to about 1200, and then we filter out what we don't want to get the target that we want. So it's non-monochromatic, non-coherent, it's defocused. versus a laser light is monochromatic. It's always going to be listed by the one wavelength of light. So it'll be listed as a 1540, pulse dye laser at a 690, or a 1565. 2940 is another one. The CO2s are going to be 10,600. So they're monochromatic, they're coherent, and they're parallel light. But when you're talking about a CO2 laser, that is basically creating a second or third degree burn. It's ablative in the sense that we're vaporizing everything in its path. High risk, high reward, because when you vaporize everything in its path and you give someone a second or third degree burn, they have to stay home and medicate that so that we don't get an infection on top of that open wound, right? So with IPL, we're targeting reds and browns. That's what we want to address. That's what we're filtering out. So when you think about all of these different pieces, what I want you to remember is we're targeting chromophores. What is a chromophore? Melanin is one, which is going to be, pigment. And then blood is the other one, oxyhemoglobin. So think browns, reds. And then the third one is water. So water is a chromophore. And then the other one is exogenous pigment. So think of tattoos. That's pigment, but that is a type of chromophore, even though it's exogenous. So I'm going to go through this pretty quickly because I want you guys to just understand the highlights of this. So IPL, we're targeting reds and browns. And this is the number one reason why people have what's called a photofacial, but it's crossed over into eye care because so many patients have telangiectatic vessels that are leaky, and they're leaking inflammation on the front surface, and rosacea is very, very common. And so when we start to look at this, meibomian gland dysfunction happens because of 6 different things: bugs, enzymes, inflammation, stasis, temperature, and obstruction. So the way that IPL works in this is we're addressing all 6 of those. Can we get there without it? Absolutely. You could do lifitegrast and thermal pulsation and omega-3 and a hypochlorous acid. You're going to get there. It's just that with IPL, we're able to get there in one fell swoop, but we can only use it on certain skin types. So we can only use it safely on someone that's really fair complected, 1, 2, and 3. Very, very cautiously can we use it in a skin type 4, which is listed over there, never on a skin type 5 or 6. So again, we're using this to treat redness, and we can also treat pigment with it. It is not covered by insurance currently. Complications are only going to happen when we do things on patients that we shouldn't be doing. So our end result is we want to have hyperemia and we want pigment to go away. So when you do this, you're going to test spot 1, 2, and 3, like out here, and then you're going to just keep going across the face. These are before and afters. You can see how much redness is reduced, how much better her skin looks. Do we have work here still to do? Yes. Rosacea is a chronic condition, just like dry eye disease. This is not going to be fixed overnight, but you can see the results. This was my patient earlier that I did Botox on. So we also did IPL on her, helping her with her MGD. And as I'm moving across there, I'm getting rid of those telangiectatic vessels as well. There's a solar litigeny that you can get rid of. That's what that pigment looks like when you treat it and it starts to flake off. The temptation is to pick at that. Do not pick at that. That melanocyte is dead. That melanin is moved to the surface. It will just slough right off like coffee grounds over the next 7 to 10 days. That's the kind of endpoint that you want to get, darkening of pigment and erythema. And the way that I understand right now, there's about 47 of the 50 states that can do this. In some board laws, it is gray. So always, always, always ask, what you can do in your state and what you can't. But I also use this to do chalazia management for patients that don't want to do a Kenalog injection and don't want to have an INC. I use this as well. And laser resurfacing quickly. Ablative versus non-ablative, we're targeting water, right? So that stubborn, crepey skin around this periocular region, you get beautiful results. And this is a patient, this was after her second one. And I cannot wait for you guys to see her third one. She's coming in for her third one this week. So stay tuned, I'll have more. But she just looks, she just glows. And those fine lines and wrinkles just makes a world of difference. You can combine these. You can do a non-ablative with an ablative. It's more aggressive. Patient has more downtime. The way that you choose this is what the patient wants as an end result, how much downtime they have, and honestly, what they can afford. And so this is all things that you can do with laser resurfacing. So remember, I was talking about building collagen, and this is a longer term way to do that. And again, those periocular rhytids just look amazing, and that volume fills in. This is what your endpoint is going to look like. I went back, of course, and like fixed those, spaces that I missed, but I wanted to put this on here so you guys could see what a clinical endpoint really looks like for a patient. That's a different laser, a 1565. So clinical endpoint's going to be that erythema. And then the last piece to this is radiofrequency. This one, its target is water as well. And so for radiofrequency, you can do this on anybody. It's what I call colorblind. And what we're doing here is we're creating a dermal injury by heating that dermal layer to 42 degrees Celsius. And once we do that, it causes inflammation. And when you cause inflammation, now you have fibroblasts that come back in. They start to chew up all the bad stuff, and then you start to lay down collagen again. And because remember, we're losing that as we have more birthdays, we have to bank and put collagen back in. And you can do non-surgical treatments of ocular adnexa. You can prolong blepharopigmenation surgery. You can treat fine lines periorbitally, that is on label, lateral hooding, dermatochalasis, and ectropion. Because, so think about it this way. IPL is great for reds and browns. So it's really good for skin color, and it actually will improve skin texture as well. Radiofrequency works beautifully for skin tightening. And then laser resurfacing does all of the above. And there's how it actually works with RF. So that first bit, and you can see I did the right side of my face. You can already see that my eyebrow is higher on that side. My eye is more open, and that cheek is more full. So when you have that, that's the initial inflammatory phase, that first 48 hours. And then that starts to diminish, but then you start to lay down collagen again. And then you just continue to build on that. So you'll do multiple treatments. There's RF before and after. Typically by decade, I'll do one, I'll do 2 in their 20s, 3 in their 30s, 4 in their 40s. But you can get some really cool results with this. And this is great for patients that don't want to do anything surgical. Like this was probably a patient that didn't want to do anything surgical. Maybe they're on a blood thinner. Maybe there's multiple reasons of why they wouldn't want to do that. But this is something you and I can do every day in our practice. And so how do we incorporate that? We ask great questions. And these are things that you can do every day to start these. Don't be intimidated by this. This will be in your handout. And there's lots of opportunities here to really dive into, whether you're the one doing it, whether you have an esthetician that can do it, whether you're co-managing, maybe you hire an oculoplastic surgeon to come to your office once a week. There's a plethora and millions of ways to do this. I just wanted to give you guys a snapshot of what I'm doing and how much fun this is. And adding oculoplastics is really part of comprehensive eye care. Okay, and I had 2 more. Did I have 2 more polling questions?
Yes, you do.
Okay.
I'll launch this one right now.
Launch this one and let's see if everybody stayed tuned. So radiofrequency can be used for what? Skin redness, skin pigment, skin tightening, or skin texture. You guys are all going to get this right, I know.
And I was able to take your 233 megabyte handout and get it down to like 1.8. I sent it earlier. I'm not sure if I announced that. I'm going to send it again so people can have it. And then if anyone needs it, they can just email me because it's not going to be in the links. The only thing that will be in the downloadable link in the 645 email and the post-event emails is going to be the little handout that you gave, if you want to talk about what that is again.
Yeah, so use that handout with patients, right? Because there's the top of it is the beauty blunders. So start to think about that. And maybe that's a questionnaire. I use a questionnaire in our office, do you want your eyes to be more open? Do these kinds of things bother you? Look at patients, and even if they don't check it, have a conversation. And then if they check it, have another conversation. Oof, skin tightening, 60%. Look at you guys, so smart. So radiofrequency is for skin tightening. So just to recap, IPL is for redness, pigmentation. Think photofacial reds and browns. And then radiofrequency is for skin tightening. Laser resurfacing really does a nice job with skin texture and tightening and rebuilding volume as well. So, and then our last question is what we're going to put in the chat box. So I'm curious, like, what kinds of questions do you guys get? When you see something, do patients ask you, questions about their lids, about their lashes, about cosmetics? What are you guys hearing that are in the trenches every day? Did I miss anything? I'm really curious as to what you guys hear and what you need help with, or, pearls that you can give the rest of the group around these kinds of conversations.
So people are replying and answering in the chat, like 20 out of the 85 that we see here. It says, what questions do you ask your patients? So that these answers go in the chat box. Is there anything in there? So you don't have to reply to the poll. Dr. McGee was looking for any types of replies into the chat box.
Let me see if I can see the chat, just to see if there's any. I'm going to answer questions as we're going through here. I love that. I live in Miami. My answer might be everyone. Is PRP for under eye less likely to blind you? So no. Anytime you put a needle underneath and you get into a vessel that we shouldn't be into, so what you'll find, and what I recommend, is people use a cannula if you're going to do that, because you're less likely to cause a problem. It's less controlled, but when you're really good at it, you also have less complications. And PRP does not last very long. It only will typically last maybe 6 months, if that, and it's fairly expensive to do. To answer this too, I also have an injector. She works about 2 miles from me, and she's been injecting for about 20 years. And so she and I refer a lot of patients back and forth, and I completely trust her. She is a really good injector, so look for people around you like that you can also, bring into your referral fold. So how long does the collagen production from RF compare to laser treatments? So when you're doing laser resurfacing, you're definitely going to get more quickly where you want to be. And it depends on if you're doing ablative versus non-ablative. So an ablative laser, you're going to have a lot more downtime and a lot more risk for complications, but you're also going to get the most effectiveness. And then when you move to non-ablative laser, you're still going to get pretty close to what you would get with an ablative laser. It's just going to take more treatments. And then radiofrequency does a great job with fine lines and rebuilding collagen, but it's a marathon, not a sprint. So this is where your photography really comes into play too. And, making sure patients fully understand that. And for RF, you're going to do those treatments 4 weeks apart, and you're just going to continue to build collagen. So, you do 4 over 4 months, and then you'll do a maintenance like every 6 months. But it's a much slower process than with a laser treatment. So ultimately, when you're choosing this for patients, again, it comes back down to what is your end result that you really want, and how much downtime do they have? And because it's a lot more expensive too, then, that plays a lot of times into this as well. So one question was, can I speak on low level light therapy? I do not have that technology. There's definitely lots of information happening in that space, but I can't speak to it because, I've looked at a couple of just peer-reviewed articles, but I haven't seen the studies for it, and I don't have any hands-on experience with it. Discoloration in lids under eye bags. That is a really common one. So I would encourage you, pull those 2 studies. Those 2 papers, they're both about, 26, 28 pages long, but that tells you how complicated that is. But man, it makes it a whole lot easier to answer that question, right? And then, a lot of people are saying they get lots of things about upper lids, mostly will my insurance cover my lids, how to treat puffy lids. So that goes back to that knowing why it's puffy. Mascara that's not irritating, neuromodulators, any preference with Botox and Dysport. So my experience with Botox, Dysport, and Xeomin has been that Botox definitely lasts longer. It has a lot more places that you can put it that's on label. There is one study that came out of, I want to say Baylor, and they looked at Dysport, and it can act faster, meaning that when you inject it, you might get 24 hours more ahead of Botox, but at that 2-week mark, they're exactly the same. So technically, they're not really interchangeable. They are same molecule, but packaged differently. I've seen metallic deposits in the lower lid fornix and conj areas. Thoughts? So yes, lots of thoughts on metallic deposits, because that typically is coming from the shimmer in eyeshadow, which happens to be usually ground up seashell or mica, which is a ground up stone. So all of that will deposit in that lower lid fornix, and then it gets in the conj, and then you have migration into that tissue that you can't get out. Safest, best eyelash lengthener on the market. So honestly, I like coconut oil. And when you start talking to patients and they stop using all of the bad stuff. So before I understood even what I was doing, I was a heavy Latisse user. And then I started seeing what it did to my meibomian glands. And I was using bad mascara. So when I switched to Eyes of the Story and I started using coconut oil, my lashes look better than when I was using Latisse. So that's an N of 1, but just food for thought. And if you do IPL on the lids, do you have a video of eye shield placement? Yes. So when you do IPL on lids, you have to have metal corneal shields in place. So I use a 26 millimeter metal corneal shield, put a drop in of proparacaine, put a drop of Refresh liquid gel in, and then I put those shields in, and that's how I do lids. And then I don't do RF on the eyelids. Can you? Yes, but you have to do plastic corneal shields because you cannot have metal anywhere because you'll cause a spark. But when I do periorbital around here on RF, I'm pulling that skin so that I can get right on the bone. You don't want it. You want to, when you're treating on the periorbital, you've got to be on bone. You can't be on soft tissue. There's a nice summary of mascara. Yes, and Tyler's that are more contact lens compatible. But here's the thing, that summary in Tyler's does not have all of the ingredients that you want to avoid. There's some things listed in that are not super beneficial. So I used to say Almay, Clinique, Physician's Formula were all good until I looked at the ingredients and realized that they had lots of bad offenders in there. So be careful with that list. And do I place coconut oil at the base of the lashes? I do. I paint it on with a spoolie. So you can buy those, like the mascara one, that tip of that's called a spoolie. So I use coconut oil and I use that spoolie and put it at the base and just condition the lashes. And then when will you recommend surgical blepharoplasty instead of pharmacological treatment? That is lots of times driven by the patient. So if they have, lash touch, if they have funny head positions, and it's a surgical case, I will definitely talk about surgical blepharoplasty. But I like having here's what we can do today, here's what we can do tomorrow, here's what we can do long-term. So I talk about the pharmacological treatment as this is a short term, but hey, this is a great option for 6 to 8, maybe 10 hours a day if you don't want to do something surgical. Radio frequency can also tighten. So we're building collagen there and we can put things off longer. And then last resort and the last piece is a surgical blepharoplasty. So it's really driven by what the patient wants to achieve and what you see as well. So think of that kind of good, better, best. Like my patient that was on Upneek that had a bleph, she didn't want to have another one and she loved it. So any thoughts on the gene expression changes from BBL versus IPL? So same technology. And when you look at the study that Bitters did that came out of Stanford years ago, when you look at what's happening histologically at skin and photo immunomodulation, you are making more collagen with that photogenesis. And when they looked at that, they took patients, and this is a great thing to talk about with patients too. When they took patients that had, and in that study it was BBL, but it's the same technology with IPL. They took patients that had BBL, looked at how old they were before the study started. So they had judges look at photography, and the median age of this panel of patients was 45. So over 10 years, the patients had 4 sessions of BBL 1 month apart. They could not have neurotoxin and they couldn't have anything surgical. In those 10 years, at the end of that, they took that same panel of patients, took photography and judged them again. And the median age in 10 years was 46. So we basically stopped time almost. And so that is the power of photoimmunomodulation and what you're actually doing to the gene expression in the skin. So what you have to be really careful of is if you have anything that you think is dysplastic, that has to be biopsied first. You do not do IPL, you do not do laser over the top of that. You get a biopsy and then you move forward with your treatment. Other questions? Man, you guys had great questions. I love this.
I think that's about it.
Okay.
Yeah. So can you see my screen there? Does it say thank you, Joe?
No, I'm still seeing Selina's screen.
Let me stop mine.
All right. Let me see if I can now get this out of the way since that all kind of moved. And do you see the thank you now?
We do.
All right. So thank you, Dr. McGee. We do a lot of, as you know, I know you do a lot of lecturing glaucoma and OCT interpretation. Joe does neuro. We do a wide bandwidth of, and we wanted to change it up tonight. And you certainly met those expectations by doing the Oculoplastic Optometrist. It was, like I said, I didn't hear it before. I know you as a speaker, and this really changed it up. And I think get great reviews on this. So thank you for doing that.
Absolutely.
Joe?
I thought it was terrific. It was a great change of pace. It is provoking, thought-provoking, and practice building. And I always like the review of anatomy, which I think is important for everybody. So thank you, Dr. McGee. We really appreciate you being here.
Thank you.